Nerve Committee, focusing on update in peripheral nerve tumor. The session will be chaired by Dr. Christian Heinen and Dr. Debora Garozzo. Dr. Debora Garozzo is a neurosurgeon subspecialized in peripheral nerve surgery. She is a professor at the Mohammed bin Rashid University in Dubai, specialized mainly in peripheral nerve surgery, with special focus on brachial plexus, reconstructive and peripheral nerve tumor in neurofibromatosis, as well as general neurosurgery. She organized many national and international educational courses and meetings as a chairperson. And her co-chair is Dr. Christian Heinen. He is the head department of neurospine and nerve surgery, affiliated to University of Oldenburg. His main clinical research focus is peripheral nerve surgery. He was the chair of the peripheral nerve surgery of the AASNS and also the German Society of Neurosurgery peripheral nerve section. So Dr. Heinen and Dr. Garozzo, the stage is yours.
Debora, please.
Okay, so first of all, I have to say that as chair of the WFNS Peripheral Nerve Surgery Committee, I'm extremely happy of having established this collaboration also with the Asian Australasian Society. We peripheral nerve surgeons are trying to integrate as much as possible peripheral nerve surgery in general neurosurgery, and I think today's webinar is going to be a good example of the importance of peripheral nerve surgery in everyday neurosurgical practice. I think that today is going to be an extremely interesting day. We are going to have an overview on peripheral nerve tumors that is going to be offered by Dr. Nora Dengler, who has an incredible experience related to the management of these lesions. Then we have Professor Kate Drummond that is going to talk about neurofibromatosis, offering us a general perspective on this genetic disorder. And I will be the last speaker, trying to illustrate what are the peculiarities of peripheral nerve tumors in patients affected by neurofibromatosis. We also have the privilege of having as co-host for this and co-chair for this meeting, Christian Heinen. Christian has a lot of experience in peripheral nerve surgery too, and I'm sure that he is going to offer us some good remarks after the lectures. And of course, we are open and we welcome questions. So maybe we can start, and I think Christian can do his little introductory speech, and then we can have Nora starting with the lectures.
So hello to everyone. It's already been said all over the world, and thank you for setting up this fantastic webinar. Just for whoever has questions, please put it to the question and answer field, so we will try to respond to all of the answers that have been posted during the talks. If there are urgent questions, we can do it after each talk, and if it's okay to have a general discussion at the end, it's also fine. So just put your questions to the Q&A. Well, it's a huge pleasure to introduce Nora. Debora already introduced her. So Nora is one of the leading peripheral nerve surgeons in Germany and the actual chair of the Peripheral Nerve Committee of our national society. And not only that she's a very experienced nerve surgeon, but she also did an incredible job to implement a peripheral nerve tumor register that is, as far as I know, one of the very few ongoing, not only treating benign, malignant tumors, but also all kinds of benign tumors. So this is an incredible work, and we are very happy and proud to have Nora among us. So Nora, please share your experience with us.
Christian, thank you very much for the kind introduction. It's a pleasure to be online with all of you at this time of the day. So in Germany, it's around noon, and I will have about 20 minutes to show you an overview on peripheral nerve tumors. I want to have a short notice on my potential conflicts of interests when my electronics are working. Let me just, yeah, I think we are working now. So I did part of an interdisciplinary guideline work. I was PI of the Peripheral Nerve Tumor Registry that we started to build in 2017. And there was some time when I was on an advisory board of election, just to let you know my potential conflicts of interest. So what is important for me, as we potentially do have an audience which is not always into peripheral nerve tumors, I want to, well, think about when do I think of a peripheral nerve tumor, which I think is a very important question. And I will also bring you some results or some ideas why this is so important. Of course, we usually focus on benign peripheral nerve sheath tumors. I want to give you a short insight on diagnostics and therapy. And I will also talk a little bit about rare peripheral nerve tumors, about the potential malignancy, and I will just give a short view on multiple nerve tumors, as I do know that my other colleagues will talk about these topics in more detail. So why is it so important to have nerve tumors in mind? And there's some nice work done by my appreciated colleague, Dr. Urschels from
Nora, we can't see your screen.
Can't see my screen.
No, could you share again? I can't see it. Can everyone else see it?
Of course. Can you see now?
I can see.
Yes.
I see the
See
screen.
well.
I can
Okay.
see
I
as
see
well.
the screen very well.
Sorry,
All
must be a problem
Yes,
with me.
we
I
can
can't
see
see
it.
it.
Okay, good. Why is it so important to have nerve tumors in mind? There was some nice work done in a large single center study of patients who came to them for a re-surgery. And what was the reason why a recurrent surgery had to be done? There was misdiagnosis in 60% of cases. In 18% of cases, a peripheral nerve sheath tumor was misdiagnosed as a cervical spine syndrome or lumbar spine syndrome. Sarcoma was another misdiagnosis. A nerve entrapment syndrome was diagnosed in some cases of peripheral nerve sheath tumors. Malignant lymph nodes were present or others. So there is a probability that nerve tumors are not well diagnosed. And this study also showed that this could be the reason for mistreatment. And what can be evaluated as mistreatment? This could be a prolonged conservative treatment which led to irreparable damage. So if there's already motor deficits present, due to the fact that the nerve tumor did grow, it was not possible to repair this motor function. There was some unnecessary invasive diagnostics done in some cases, and also some wrong surgical treatment was performed based on the misdiagnosis. And also an inadequate surgical technique could be used due to the fact that the nerve tumor was not diagnosed correctly. So when do we have to think of peripheral nerve tumors? Please think about peripheral nerve sheath tumors or peripheral nerve tumors in general if there is a palpable or visible swelling in the course of a peripheral nerve. Also, if there is a sensitivity to touch, a so-called positive Tinel sign. And of course, if there are any neurological deficits, please keep in mind that the reason for a swelling could be a peripheral nerve tumor. However, the good news is that in 91% of nerve tumors, the tumors are benign. This is an overview about how nerve tumors can present, and this can be different due to the fact that in the large cohorts that have been published, the amount of patients or the rate of patients who do have a genetic diagnosis, the most important one is NF1, and I think this is going to be talked about in detail soon. Some of the symptoms that are present are weakness, numbness, the positive Tinel signs, as you see in the upper line. Pain can be present, and of course, there's a possibility that only a mass is present. And if you compare those two studies, you see that pain is more often present when the amount of patients who are included have a genetic syndrome like the NF1. So if you look up the large studies of peripheral nerve sheath tumors, please keep in mind that the presentations can differ according to the rate of patients included that do have a genetic tumor genesis. So what to do if we think of a peripheral nerve tumor? And I think the one entity or the one modality which is used most is the MRI, of course, T1 with contrast. But I also want to bring light or shed your attention to some more recent possibilities. For example, the ADC or the fiber tracking, which can give us an overview or an idea which entity we have to do with. And I think MRI is an easy tool to nicely show whether there is a tumor present or not. And if you look on the left-hand side, you can nicely see that there's something happening in the thoracic outlet, in the lower plexus nerve roots. And usually, if you go a little bit deeper, if you do MR neurography, you can see that the nerve carries the tumor. And if you go into fiber tracking, you can see whether the fibers in the tumor are diverged or whether they diverge or whether they go simultaneously or homogeneously along. And this can give you an insight whether or not. And there is another modality which we really like to use in the last 10 to 15 years because some higher frequencies came up, and especially if you have superficial lesions, it's a very good technique to visualize nerve sheath tumors is the high resolution nerve ultrasound. There has been some nice work been done on that. We were even able to classify lesions due to or based on the visual impact that the ultrasound image gave us. So this is a good tool, and if it comes to the guideline work due to the latest publications, in our area here, we are able to use the high resolution ultrasound instead of MRI. So both of the techniques are possible. Potential diagnostic tools to diagnose it. When it comes to the fact or to the, especially the NF1 patients, one has to keep in mind that there are new tools available to give us some hints in terms of the standardized uptake value in F18 FDG PET. So the metabolism of the tumor can be quantified, and especially if it comes up to the fact where we think about a malignant peripheral nerve sheath tumor, usually the size of the lesion can give you a hint to that, and as well as the presence of a pain syndrome in rest, or whether there are some motor deficits present which developed very, very shortly. Then you have to think of a malignancy, and then sometimes it does make sense to use a PET image or an MRI with ADC. This is a little newer data, and there were some nice studies showing this can be of help, especially when it comes to patients who suffer from neurofibromatosis. So just to keep that in mind, I think Debora is going to talk about that, and Kate is also going to talk about that a little bit more in detail. So when is surgery indicated? And this is some data from our peripheral nerve tumor registry. It's 171 patients from multi-center data. And this is just an idea of how our entities were distributed. Most of our patients had schwannoma, around 71%. A little bit lower amount of patients had neurofibroma, and we also had some rare lesions included. And one always have to keep in mind, when should we perform surgery? I think surgery should be performed when the benefit outweighs the risk. And this is important to think about what are the benefits of surgery and what are the risks. And I think this has to be something where the patient should be really counseled in detail, and the latest studies can give us a good idea when to think about what. Here you see on the right-hand side how the individual health-related quality was before surgery in most of the patients. Keep in mind that in the usually Western countries, if you come up with the EQ 5D5L, the overall potential of health-related quality of life, which is rated between 1 and 100. 100 is the maximum scale. Usually in our Western societies, people range from, well, 79 to 85 on their scale. And if you look on the right table, you see that the mean at T1, and T1 was at the time preoperatively, was 72, which gives us an idea about the reduction of individual health-related quality in patients who have a peripheral nerve chest tumor. So sometimes in neurosurgery, people think, you know, that's just a benign tumor. Why should people be affected by that? But actually, this data shows nicely that there is a severe reduction in life quality compared to the normal population. And if you look at the T2 on the right-hand side on the table, you can see that after surgery, after follow-up time, the life quality increased significantly. So you come up to normal values, which are comparable to those in the general population. So please keep in mind, people with peripheral nerve chest tumors have diminished quality of life, and surgery can improve that. However, of course, we also have to think about potential neurological deficits. And this is also a nice study which has been performed multicentric in Canada as well as in North America. And there are very, very experienced surgeons who brought their patient data into that. And you see that the black bars represent transient deficits after surgery, and the one who are with lines are permanent. And you can see that usually the paresthesias are only transient after surgery, and usually they go away afterwards. However, you have to keep in mind that in 3% there can be permanent deficits after surgery. And I think this is important if you explain your patients potential risks of a surgery, that this multicentric data from experienced surgeons show that there also might be, in a very, very low number of cases, there might be neurological worsening. However, this is a group, this is why I wrote it on the right-hand side. There were a high proportion of patients included with NF1, NF2, and NF3. And this also, in my point of view, is a risk if you do have a high proportion of patients with a genetic disease that they may suffer from neurological worsening. However, we don't know in this group whether there was neurological worsening without surgery anyway. So what is the possible surgical outcome? This is data again from our registry. And you can see that in terms of pain, if you look to the right image, there is a significant reduction of pain after surgery. So we do not only have an improvement of health-related quality of life, but we also do have a significant reduction in pain after surgery, which can be a good advisor for surgery. So as Debora is going to talk in deep about the treatment, I will just shortly give you two, well, let's say, main goals of surgical strategy. And one has been published quite some time ago, and I think it's one of the most important, is, of course, preserve the nerve. And if you look at the pictures who show step by step how a peripheral nerve chest surgery can be performed. This is an example from the posterior, from the femoral nerve, and you can see that the tumor is exposed widely. You can see the proximal as well as the distal part, and you lose the nerve in the tissue, and then you go there usually with a forceps or with a monopolar probe to check how the motoric fibers are represented in the capsula, to make sure that you find a spot where you can easily enter the nerve without doing harm on the potential fibers that are running in the pseudocapsula. And then you are careful in loosening the tumor all around, and you of course visualize the tumor-bearing fascicle. What I do is I usually put a probe on that to check whether this is motor function or sensory function, and after that I decide whether to cut it or not. And this is another little bit more a little bit more focused overview, which brought up for the first time the idea that there might be a pseudocapsule as well as a true capsule. I think this is a very interesting concept, which, well, in my experience, is true in most of the cases. So you do have the pseudocapsule, which can be part of the epineuron. Sometimes you have fascicles in there, and then you go a little bit, dig it a little bit deeper. And this is a plane which usually shimmers a little bit of gold, and this is why this is performed, or this is called gold or go for gold. And there you can see nicely that the tumor can be exposed, and you have entering fascicle, which you have to decide on whether this should be cut or not. So for summary, this is the summary on how to perform surgery, but I think we will dig a little bit deeper depending on the different entities which can be present. This is an example of the usual case, the benign schwannoma, which can be treated like this. However, please keep in mind that there might be some rare entities which also potentially lead to different conclusions from the surgical perspective. And this is the perineurioma. Also a very rare tumor. However, there has been some data published. This is an amount of 32. This is an amount of 32 patients, and it's a rare disease. However, this can be identified in the MRI, and due to this study, which has been performed by the Mayo Group and published in Brain 2009, you can see that there is a characteristic picture of enlargement of nerves, and usually this is in male young patients which come with a motor deficit. Then if you have this constellation, you should please keep in mind that this could be a perineurioma. And on the right hand side there is another collection of perineuriomas. It's 30 patients. And the concept on the right-hand side by the Günzburg group here in Germany is a little different. They go for biopsy. This is in contrast to the Mayo group, who say, you know, if you have an MRI, you know whether it's perineurioma or not. But the Günzburg group showed their data, and they were able to show that some of the patients who have a classic MRI picture have a CIDP. So a chronic inflammatory demyelinating neuropathy. So sometimes it does make sense to do a biopsy to diagnose this entity, which can be treated, for example, from the neurologist to potentially, increase neurological function. Some other rare tumors are lipomas. And the Mayo Group was, I think, very, very eager to show recent developments and to do some nice classifications. And lipoma can be present in nerves, can be present extraneurally, and this can lead to differences in the surgical strategy. So the location is of importance. There can be really benign lipomatous lesions in the nerve, but also there is a risk of liposarcoma. So this, I think, has to be kept in mind. And there's an entity which I sometimes come across. If you care a lot for people with nerve tumors, you sometimes get into contact with desmoid tumors. These are lesions which are also called aggressive fibromatosis. It's often females that are affected. There is a certain growth induction during pregnancy, so there are hormonal reasons why these tumors may grow. And you can see in the MRI, in 80% of patients, you have no contrast enhancement. So you have a lesion close to a nerve or in a nerve without contrast enhancement. You have a severe infiltration in the region around it, and you have no central necrosis. Histopathology is classic, and there may be some muscle marker impressions and genetic mutants who make it more. Sometimes people with these genetic lesions have a higher risk to have desmoid tumors. So this is just a short resume of rare tumors and nerves. However, I think what could be interesting to most of you is what to do in case of a suspected malignancy. And I think this is one of the papers, also from the Mayo Group, who brought up the discussion whether percutaneous image-guided biopsy is always the right strategy in malignant peripheral nerve sheath tumors. And it's for me important, or rise the awareness that malignant peripheral nerve sheath tumors are sometimes treated by a neurosurgeon, and sometimes it's treated by an oncological surgeon, and sometimes it's also treated by a plastic surgeon. So the basic concepts, how people do approach these lesions can differ. And this study just brought up, I think, not shocking, but the idea that nearly 1/3 of patients that underwent biopsy had a biopsy-related complication first time rose the awareness that biopsy can be harmful in some cases. However, if you, this was, I think, from the group of the Netherlands, very nicely shown that whatever discipline treated the suspected malignancy can have different concepts. So you see in the left upper part, you see that usually surgical oncology first goes for biopsy. Neurosurgery, there is an amount of neurosurgeons that do not go for biopsy. Plastic surgery does some radiology first. And if you go to the right part and lower part, you see, especially when it comes to core needle biopsy, this is the strategy which is usually performed by the surgical oncologist, and the representation of the blue bar is lower in neurosurgery as well as in other specialties. So keep in mind that whoever treats a malignant peripheral nerve sheath tumor has potentially different aspects in mind. So usually a neurosurgery surgeon thinks about function, and the surgical oncologist thinks about overall survival. However, I think it does make sense to come up in a multidisciplinary setup and to also talk to the patient to, well, have the right decision. And this was nice work done in a nationwide cohort study, a patient with malignant peripheral nerve sheath tumors. And you see what hazard ratios come up in this type of patients. So what are factors that predispose for death? And of course, it's age as well as the tumor size and the location. But if it comes to tumor margins, there is not a significant difference between R0 and R1. However, when you perform R2 or biopsy only, then there is an increase in hazard ratio in this type of patients. I think this is the first time that there has been very nice overview on what is well, also from the treatment aspect, increasing the individual hazard ratio. And this is a nice overview, and I just want to give a short hint on that because I think this is going to be covered by my other colleagues in the next talks. There are basically 3 types of neurogenetic diseases which can lead to multiple tumors. This neurofibromatosis type 1 is type 2, as well as schwannomatosis. Well, in our part here, this also underwent a change of naming. So we now address that a little differently, but this is usually analyzed some changes. And if you look in the lower part of that table, you see that the gene analysis may differ. So the NF1 gene has to be analyzed in patients who have a suspicion of neurofibromatosis type 1. And NF2, of course, usually you come up for NF2 if you have an intracranial manifestation. However, we do know that there is also a schwannomatosis, which comes from deficits or damage in the SMARCB1 as well as the LZTR1 gene. And I think this last entity is kind of challenging due to the fact that those patients have severe pain syndromes. They are usually not well diagnosed. However, if you care for peripheral nerve sheath tumors, you come up in meeting some of them. And you have to keep this in mind, which may lead to such a diagnosis and which diagnostics to perform, and to bring in also some pain specialists to treat them well. And in schwannomatosis, when you resect a tumor, not always the pain syndrome goes away constantly. I think this is important to keep that in mind. So let me provide you some take-home messages, and I want to keep it simple, not stupid, but short. Please think of nerve tumors. I think this is one of the most important messages for nerve surgeons. Of course, an orthopedic surgeon it's okay when he not thinks first time for nerve tumors, but please, as a neurosurgeon, think of them, keep it in mind that they can be present. Please counsel your patients. I try to provide you with some information how to counsel your patient and what is the evidence that you can include into your counseling. Preserve the nerve whenever it's possible, and be aware of the rare entities that I just brought up at the middle part of my talk. And in case of malignancy, I think it is good to have an interdisciplinary team. And sometimes, like it is in life, you have to be empathetic and also have to step in the position of an oncological surgeon, but you don't always have to do what they tell you to do. So thank you very much.
Thank you very much, Nora. Excellent talk as usual. And I think a lot of very interesting matters and issues were raised, and we could discuss, for example, the question of needle biopsy forever and ever, because this is a very important topic, and I really appreciated the way that you presented different approaches from different perspectives. I mean, if you're an oncologist, you will see malignancy in everything, and we don't. So there's one question from Andre Überreiter from the audience. Something that was not addressed is, are there any different treatment for recurring tumors after surgery? And I think this is an important question because as you showed beautifully in your pictures and the works, if this is let's say, a tumor that is not spoiled so far, schwannoma, I mean, we all know this is a huge pleasure to remove it, to find the anatomical planes and to take it out. But once these anatomical planes do not exist and we cannot go for gold right away, what is your approach? So this is, thank you, Andre, for this question. Whoever wants to answer, please.
Well, I usually look at the pictures, whether it's an MRI or whether it's an ultrasound. In recurrency, I look more. Why? Because not every swelling of a nerve is a recurrency. We all know that if you look at a nerve that has been operated on beforehand, looks different than a normal nerve. So it does make sense to keep in mind or to have a alignment of all the pictures that have been performed before and to compare them really in a differentiated way, and to see whether there is growth in a swelling of a formerly operated nerve. So the growth factor is of importance. And of course, there always is scarring. And I always use neuromonitoring. And I think in a recurrent tumors, experience is of much importance. I think I'm still super careful, but the eye develops. And if you have experience and you can differentiate between scarring and tumor and alive fascicles, I think it is of much importance to, of course, have the microscope with you, to be super careful with surrounding structures which are intact but potentially scarred, to do no more harm. And I would always advocate patients that the potential of giving a neurological deficit is higher in a recurrent tumor. However, I also had some good cases where they had severe pain due to scarring and tumor recurrence, and we were able to solve that surgically. But I would advise my patient even more for the potential of neurological deficits after surgery. I don't know how you would do it, Christian. Would you agree?
Well, absolutely. I mean, in case of recurrency, that means that it has been operated on previously. In addition to the tumor condition, you add the trauma condition. So in that case, I treat the tumors as I would have treated a traumatically damaged nerve. So I go for the healthy portion of the nerve first, not directly to the scar. So I always address the healthy portion of the nerve before, and so proximal and distal to the lesion. And then, as Nora said, with neuromonitoring, which I think is mandatory for any kind of nerve tumor surgery, not only in recurrent situation, but all the time, at least to have the electrostimulation for the motoric answers. I would also add intraoperative ultrasound, which is very easy to use. So if you're used to ultrasound outside the OR, so why don't you use it inside the OR? So this is why we always add this feature on to be even well in a better position to distinguish the healthy portion from the tumor portion, and especially in the benign tumors, you always need to ask yourself if you really need to remove everything. So the treatment concept changed because, as Nora pointed out perfectly, most of the lesions are benign. So, and as Nora also pointed, I just want to stress it, it's nothing new because Nora said it all. It's just to stress it that the function is number one in nerve surgery, in nerve tumor surgery. If you have a benign tumor, I would prefer to leave something, some whatever not clear tissue, than to damage the median nerve or whatever other nerve. So I don't know how you. So I changed from the very radical approach to prefer to leave something if necessary. Most of the times it's not. If you find the rain planes, I mean it's almost you know, it comes out by itself. But in case of doubt, I would leave some of the tissue and not damage the nerve. Please, I think Yigal was first.
Yes,
Please.
thank you. You know, I wonder, Nora, talking about high cervical region schwannomas, you know, it's funny, just this week I have a young lady with a mass here just beneath the mandible, and the MRI was strongly suggested of a vagal nerve schwannoma. But my question is, you know, taking into account the possible complication that may occur in surgery and high cervical exploration, does the discussions that we have for intracranial schwannoma of surgery versus radiosurgery at all exist in this field, especially for recurrent tumor? Nowadays we can give a very accurate radiation to the cervical spine with all the technology that is available. Is this an issue? Is this an option?
Thank you for your question. When it comes to the area of the cervical or neck region, we have to keep in mind that there might be gangliogliomas. So we have vascular lesions, especially if it is in the vagal area. And I think for them, radiosurgery is a good option because we do know that when we resect them, there is a high potential of deficit. If it comes to a normal schwannoma, also in the neck region, I think usually they can be resected nicely. Of course, vagal nerve schwannoma can lead to some vagal nerve dysfunction if it has not been done by an experienced surgeon, and this can conclude in a severe harm to the patient. So I see your point, especially in that location. So it would be ganglioglioma, or paraganglioma. Then I would go for radiosurgery. But if it's a schwannoma, my experience, I have one case which underwent radiosurgery, and I had it resected 13 years after radiosurgery, and this was a malignancy. So you have to keep in mind that with radiosurgery and schwannoma, and this is also known for vestibular schwannoma, that there can be a second hit from radiosurgery, which can lead to malignancy. So, of course, evidence, there are no large studies on radiosurgery and schwannoma and peripheral nerve schwannoma, but I have a few cases where I'm careful to apply that to my patient or to counsel for that. Do you also have experience, Debora?
Yeah, so first of all, what I wanted to say is that Nora, as Christian already highlighted, has actually emphasized a lot of important key points. One of the key points is the fact that during general investigation of patients complaining of symptoms that might be even suggestive of peripheral nerve tumors, very rarely this is a diagnosis which is kept in mind. And I think all of us working with peripheral nerves have experience of patients that have been bouncing from one doctor to another for symptoms that were not given a solution for, and that eventually, with the correct investigations, showed that there was a peripheral nerve tumor. I have patients that even took like up to 5 years before the tumor was diagnosed. So this is something that is important to spread awareness of the presence of this pathology. Then concerning the recurrences, I think we actually have to start distinguish between the benign, the malignant forms. And when we talk about the benign forms, I think we also have to consider that we should make a differentiation for patients who are affected by sporadic forms and patients that present neurofibromatosis. I absolutely agree with what has been said by Nora and Christian. I think it's important to consider that, yes, after we do surgery on a nerve, the nerve is not going to present the same morphology that it had before. And therefore, imaging and third, the electrodiagnostic tests are certainly essential to clarify whether we might have findings which are consequence to the surgery, or they might be related to a recurrence. I have to say that in my experience, the possibility that after a radical excision of a schwannoma, there is a recurrence of the tumor is something that I don't remember I have encountered. It's different from neurofibromas when you realize that there might be not a possibility of radical excision, and therefore you just left a residual tumor. But in those cases, usually what I have seen is that you follow up the patient, and then if there is a significant regrowth of the tumor, then you might consider that again you go for surgery. And then we have to consider the issues related to the malignant forms. Now, Nora has already mentioned that there are physician being a neurosurgeon, an oncologist, an orthopedic surgeon, or a plastic surgeon. There is something that I think it should be a starting point. Malignant forms, MPNST, are still considered in the group of sarcomas, of soft tissues, sarcomas, and they are the guidelines or the recommendations that the oncologists give for this kind of tumors are usually the same ones they give for the other malignant forms. When you do peripheral nerve surgery, you realize that you may have different histotypes in malignant forms, because we still have malignant forms which have a capsule and do not infiltrate the nerve and preserve the nerve. And then we have tumors that have an infiltrating behavior. So I think we also have to consider, if we have a tumor which is infiltrating, then you might expect that there is a recurrence if you do not do a quite large resection of the nerve and also the surrounding tissues. But we have seen that, for instance, in encapsulated forms, you can just do your surgery like in benign forms, and this is already enough. I have experience of a few patients with neurofibromatosis where the tumor was malignant but capsulated, and I just removed the tumor, preserving the nerve. And then the patient was referred to the oncologist, and the oncologist said, "Oh, no way, we have to go for revision surgery because we have to, to remove the surrounding tissues. So the patient was reoperated by a general or an orthopedic surgeon. They did the revision surgery, removing soft tissues which were around the nerve and the nerve. They caused the damage to the patient. Of course, there was a functional damage. And the worst part is that at the end of the day, the histopathology of what had been removed during the second surgery turned out to be negative. So I think we also need to rethink of what are, from the biological point of view, tumors. And that should be the starting point because we designed the plan of treatment. I don't know if you agree on what I said or if you shared similar experience with that. Christian?
I think we need to move on. We're 15 minutes left of the scheduled amount of the webinar. So maybe we can leave the rest of the questions to the end so that everyone who's online, who's put an hour in to listen, will get to hear most of the talks.
Okay, so then I grasp the opportunity to introduce you, dear Kate Drummond from Melbourne, expert from Australia on peripheral nerves, to share your experience on adult neurofibromatosis patients. Thank you very much.
So thank you, everyone. I'm Kate Drummond. I'm a neurosurgeon from Royal Melbourne Hospital, and I am not an expert on peripheral nerves. However, I find myself as the person caring for the majority of patients with neurofibromatosis type 1, which I'm going to be talking about, in my state of 7 million people, which, given that there's about, it's a condition of about 1 in 2,500 people, means there's a lot of patients with neurofibromatosis type 1 in my state. And by a series of unfortunate accidents, which is where we find most places that we find ourselves in life, I run the neurofibromatosis clinic, and this is a very difficult disease in adults. And I'm not going to talk too much about anything very mechanistic, but more about what these patients require for good care, because it's a very common inherited disease. So you will all remember that NF1 is from a loss of the gene that encodes a tumour suppressor protein called neurofibromin, which leads to dysregulation of the RAS signalling pathway. There's many different mutations, including large deletions, small deletions, and missense that can lead to different phenotypes associated with this gene loss, but this is an autosomal dominant condition, and the dysregulation of the RAS signalling leads to, in various tissues, cell proliferation, survival. And then there are secondary genetic events that lead to tumour growth within the patient. But I'm not going to talk too much about the pathophysiology, because in the end, it leads to a very wide variety of disease phenotypes in adults. So what are the challenges for neurofibromatosis care? And one of the biggest challenges is that there's not a big expert workforce to care for these patients, particularly in Australia. There's only really 2 for the whole country, neurofibromatosis clinics run by a small group of people with an interest. In Australia, there's a big problem with distance. That's not always the case in the world, but we have a large country with a small population, so it's both distance to travel and therefore cost. There's not great protocols for imaging follow-up, and many of us have probably come across patients who are somewhere in a neurosurgical outpatient or a neurological outpatient clinic having yearly scans of brain and spine for no particularly good reason, because no one else wants to do anything different or care for those patients. Poor primary care engagement. Many GPs don't feel able to care for these patients, and limited capacity for multidisciplinary care due to resourcing. So what's healthcare like for these patients? Well, many of them talk about it being like walking in the wilderness, not really sure where they're going or where they're supposed to do. And this is particularly the case where I got involved, because we realised that patients going from the Royal Children's Hospital in Melbourne to the Royal Melbourne Hospital, and this is not actually the Royal Melbourne Hospital, but it's a very old hospital, much like my very old hospital in Melbourne, where they went from the very well-resourced, shiny, wonderful Royal Children's Hospital with a multidisciplinary clinic, taking care of these patients in a very careful way, and then launched into adult care without any particular follow-up. And this is often a point where patients were lost at follow-up, and a point of great danger, because of course they're moving into the age where malignancy and other complications can occur. So they often feel like they're launching off the edge of the Grand Canyon in a car with the wheels falling off when they move into this care. So what are the priorities for neurofibromatosis care? I think the first thing that I do, which as a neurosurgeon is a little bit unusual, is concierge. These patients have multiple care needs that really involve multiple specialties, and so they need someone to coordinate. Now that could be the head of the clinic, it could be a clinic nurse, but someone needs to be arranging all the priorities for care for these patients. The biggest concern often for the patient and for myself is early detection of various malignancies, not just a malignant peripheral nerve sheath tumour, which is of course the tumour that everyone thinks of, but various other malignancies for which these patients are susceptible. Fertility, given it's an autosomal dominant disease, preservation of function, and quality of life, which has already been mentioned as being very important. But for these patients, there are so many aspects of the disease that reduce their quality of life, including the cosmetic deformities of having multiple tumours. There are many challenges for mental health being more common in people with neurofibromatosis, both due to their social situation and the disease itself, and also chronic pain. So I'll talk about these a little bit. The first being concierge. There's just so many departments that they end up running to for their care. And to have someone to coordinate care for these patients, because they always really describe it to be very bewildering. Who's in charge of what? Where should they go? Who is their first point of contact? Is it dermatology? Is it, no, don't go there. I can't look after everything. Is it neurology? Well, I can do that, but I can't look after the skin. Someone needs to take overall responsibility for the care of these patients, and this is very important, because otherwise they just get discouraged and they stop having any overview of their neurofibromatosis at all. And one of the ways that often patients come to my clinic is their children are referred up from the Children's Hospital, and then the parents and all of the rest of the family who's affected turns up and says, oh, well, we haven't been seen for many, many years, but I've got all these concerning swellings, and I've got this concern, and I've got that concern. I tried to stay and follow up, but it just got all too hard because I didn't really know where to go. So I think that's a really important aspect of care. The second one is early detection of malignancy. The really common problems are about somewhere between 10 and 13% of people may develop a malignant peripheral nerve sheath tumour. And these, are not too problematic to detect in a patient who's in care if the tumour is visible. It'll grow rapidly, it'll become hard, it'll become painful, and that becomes fairly straightforward. The problem is that many of the tumours in these patients are hidden deep in the pelvis, in the abdomen, in the chest, in the brachial plexus, and they may not be able to be easily determined clinically. And there's no really good understanding of a protocol to image for these. And so I'll talk a little bit later about some of the research that we're doing in the hope that we can have an early detection system for malignancy. Malignant peripheral nerve sheath tumour is the result of a sequence of second genetic hits, and so there may be, including loss of the other NF1 gene, and then other changes along the way, particularly of some of the very common cancer genes, loss along the way, which we may be able to detect in some ways. Other malignancies include an increased risk of breast cancer, and that needs to be thought about and is often forgotten, and increased risk of things like pheochromocytomas. So that's an important priority that is not really resolved as to exactly how we should do that. There's also a number of brain tumours that are associated with NF1, which is often how neurosurgeons get involved. You can see on the right here a number of different kinds of cancer that adults can get with NF1, and the associated brain tumours include the really classic optic pathway glioma, which, although very problematic in children, once patients get into adulthood, it usually doesn't cause a problem. And then, unfortunately, high-grade glioma and brainstem glioma are two important tumours. These are often less problematic in adults than they are in children, although there may still need to be some surveillance. The other problems are ones that I think we can all put into almost a quality of life situation. So fertility, function, quality of life, cosmesis, mental health, and pain. Fertility is a big problem and is for the patient, and is often not really covered by those who are caring for them, unless they happen to be in a clinic that is run by a geneticist, and then they're all over that, but they might not be over other things. Of course, this is an autosomal dominant condition, and the patient needs a lot of counselling as to their options. Many patients, in my experience, interestingly, just choose to fall pregnant and roll the dice for their 50% chance of having a patient with NF1, and that, of course, is their absolute right. But other options include falling pregnant and then undergoing either amniocentesis or chorionic villus sampling to determine if the child has NF1, and then undergoing a termination if so. And this is, of course, quite difficult for the parents and not acceptable to many people, which is also their right. And then in some countries, of course, it's available to do IVF with pre-implantation genetic diagnosis, allowing for the implantation of only non-affected embryos. And if this is available, this is an expensive but obviously great option for these parents. Patients often have a loss of function over the course of their life, whether it's from nerve tumours or from other difficulties, including the fact that there is often cognitive deficits associated with NF1, and there's a higher incidence of autism, ADHD, and other mental health problems. Of course, for the patients, although not clinically really relevant, the multiple tumours become a problem, and these increase with life, and this becomes an enormous focus for these patients of these tumours that appear, particularly for young women, that may start to appear on the face and worsen with age and with pregnancy. And so managing these cosmetic concerns is really becomes a big problem, and particularly with plexiform neurofibromas that we're going to probably talk about soon. There's an enormous amount of pain that can happen with these, and chronic pain is a really common problem with patients with neurofibromatosis type 1. So if we really want to look after these patients well, what sort of a clinic do we need? What personnel do we need? Well, obviously, the column there on the left, we need neurosurgeons, neurologists. These patients often have epilepsy, dermatologists, plastic surgeons. We need oncologists for the malignancies, psychiatry, genetics and fertility, ophthalmology, pain services, and a lot of social work and allied health. We really need resources for multidisciplinary care, telehealth, monitoring protocols, which are not well defined, and imaging protocols, and clinical trials and research space, and shared care models with GPs, because I can't do all of these, look after all of these patients. So for any patient, I don't expect you to read this, monitoring protocols will take all of these things into mind. And so obviously for each individual patient, whether you're doing a scan here, things like osteoporosis, breast cancer, pheochromocytoma, how do you monitor these patients for all of these complications of neurofibromatosis? So one thing that we've instituted is a checklist. Often, these patients will be seen by people who are not used to seeing patients with NF1. And so at first contact, we have a checklist of which particular problems this patient has. They may have hundreds of neurofibromas, but really no other manifestations. They may be, severely have severe cognitive problems, but very few neurofibromas. So the first thing to do is to go through the whole list of possible problems, particularly also related to their age, and then put it together after we've gone through this into a customized monitoring protocol for that particular patient. So, it might look like this. Patient doesn't have an optic nerve glioma, so they just need to see an optometrist once to ensure that there's no other eye problems. Their cutaneous neurofibromas may need to be removed if they become bothersome. If they've got plexiform neurofibromas, they probably should be imaged yearly, but that can be very burdensome, and it's difficult to know exactly what you should be imaging with. PET is not always helpful in looking for malignancy. If they're, say, age 25, they need to be reminded to commence mammograms in 10 years. So and fertility, if not current issues, need to be reassessed at each visit. So all of these things need to be customised and then worked out for the upcoming care of the patient, and then put into a, monitoring strategy, either in the clinic or with their GP. Of course, clinical trials have become important in neurofibromatosis. The main problems, this is both for neurofibromatosis and type 1 and type 2. The main agents are the MEK inhibitors, which have really become some important pathway inhibitors and have shown well in children to reduce the size of plexiform neurofibromas and also to reasonably effectively treat pain. So I think it's very important that if you're going to treat these patients, you need to have clinical trials available for them. And then just in the very last minutes, monitoring for malignant peripheral nerve sheath tumour, which has a very high fatality in patients with NF1. Monitoring for these tumours is very difficult to know what to do, and is a great fear of the patients. They are terrified of developing one of these tumours. We're hoping that you can see here that the genetic pathway to going from a neurofibroma to a plexiform neurofibroma with the loss of the second NF1 allele, and then abnormalities in CDK2NA to a typical plexiform neurofibroma, and then a number of other hits to lead to a malignant peripheral nerve sheath tumour. It's likely that these genetic abnormalities are shed into the bloodstream, and therefore a liquid biopsy analysis may be a good way of monitoring for these tumours. So we're currently collecting blood from all of our NF1 patients at every visit, and the analysis of this we are hoping associated with tumour tissue as well. The analysis of this will hopefully allow us either via cell-free or ctDNA, or perhaps methylation profile will allow us to make an early diagnosis of an atypical neurofibroma or an early diagnosis of a malignant peripheral nerve sheath tumour. So that's all I have, and I would be very happy to take any questions.
Great talk, Kate. Thank you very much, especially for broadening the view to show the complexity of these patients. And as you pointed out perfectly, this is nothing one discipline can handle alone. So we need the team of a lot of specialists involved, and not only doctors, to be able to really, well, to get the whole picture of the individual the individual type of neurofibromatosis, and to be able to treat them. And I think the monitoring and the assessing tools that you showed are excellent and are exemplary for I think this could or should be included in a lot of places that deal with these kind of patients. And personally, I find especially interesting your way of approaching the monitoring for malignization with the blood samples. Could you comment on that a little bit more, please?
Yeah, I think liquid biopsy is, I mean, it's becoming a reality in many cancers. I mean, it's in clinical application for lung cancer and breast cancer now. It would be likely that these tumours would shed DNA into the bloodstream. So if we understand the landscape of what is shed, and I think that will be, all the way from patients with multiple cutaneous neurofibromas through to patients with malignant peripheral nerve sheath tumour, we need to understand the landscape of what either the DNA or the methylation profile looks like. Then there's a possibility that we would be able to identify, for instance, cells with the bioallelic loss. So we've taken the approach that this is expensive research, so we've our patients are extremely motivated to find a cause for this problem, find a solution for the problem. So we've just been taking blood at every visit for our NF patients. We now have a very large biobank of more than 600 samples. So we're actually getting to the point now where we can start analysing them and start looking at, because it's a bit of a needle in the haystack. We want to find the patients who will develop an MPNST in the future. So I think we can actually start looking at that now. So we're collaborating with groups in Toronto and Mayo to really have a deep look at these samples, and then I think we'll have a bit of an update on that soon. But we've got quite a bit of experience with this in glioma, and so this is really sort of branching out to another area for us. And there's a reasonable chance that we will be able to do a weekly, maybe a yearly blood test in susceptible patients and have a signature that we can identify.
Perfect. Thank you very much. So far there are no questions from the audience. Okay, I think this was not a question. So
sorry, Kate. I was trying. My camera's not working. It's 10UN. That's a great talk, Kate.
Or is it just me again?
Oh, can you hear me?
Yes.
Oh, sorry, Kate. That was a great talk. Thank you. 10UN from Royal Melbourne. Is there any, besides the, I guess, the work that you're doing with the liquid biopsy, but is there any features on a plexiform neurofibroma or demographically that could predict that they're more likely to become malignant?
Okay, Christian, we didn't hear what you said before. Did you introduce Debora?
I think there was a question for you, Kate.
There was a question concerning the plexiform neurofibromas. If you have any experience on well, as far as I understood, if there are any clinical or genetic backgrounds that you would consider for plexiform neurofibromas to be more prone to turn malignant.
I don't think we know. We know that the bigger your tumor load, the bigger chance you have. I can't really answer that question. I mean, we certainly know that, for instance, PET, they all have hotspots that we all worry about, but they don't necessarily progress. I don't think that I don't think that I have any idea how I can pinpoint which ones are more likely.
No, I mean, there are the large deletions in the genes that are more prone to develop MPNSTs. And still one of the main features for malignancy or for malignant conversion is the development of neuropathic pain. So for us, aside from all the genetic workups and imaging and whatever, if a patient develops severe neuropathic pain, spontaneous, at rest, at night, and so on, this is at least, well, it's almost too late at that point, but this is a very, very strong indicator for malignant transformation of the tumor in our experience.
I think the biggest problem is that, I've learned in the general NF1 population is that there are so many patients with chronic pain as well. It is extremely common. And so, sort of sorting the pain from the background is sometimes difficult. It's very easy if a patient has pain, had no pain, and then has a lot of pain.
Yeah.
But in the patients who have a lot of chronic pain, even with the plexiforms that are not going bad, it becomes much more difficult. I think maybe we should move on to the next talk.
Yeah, there's one question from Dr. Manjul, but we can have it also once Debora has done her talk. So it's my huge pleasure, again, as has been before already, to introduce our actual chair of the Peripheral Nerve Surgery Committee of WFNS, who is doing an incredible work, traveling all over, getting in touch with everybody on this planet, maybe also already on Mars, I don't know. I wouldn't be surprised to set up these fantastic collaborations with with this huge network of peripheral nerve experts. And well, thank you for your endless dedication, Debora. And we are very happy to have you and to have you here now and listen to your talk. Thank you.
Well, first of all, thank you so much for your fantastic words of introduction, Christian. That was really very nice of you. And I do hope that you can see that I have already started to share my presentation. Can you see it?
Not yet.
Oh, okay. So then there must be a little problem then. Sorry, 1 second. Because I did share it, so I'm surprised that you were not able to see it.
No, so far we cannot see it. Maybe, or what about the others? I cannot see Debora.
No, we can't see it.
Can you or you cannot?
We don't see it.
Okay, so 1 second, I'll try to set it up again. So it's
Maybe in the meantime, there was the question from Dr. Manjul.
yeah, exactly.
With and the question was concerning if you have the multiple manifestation of lipomas and neurofibromas all along the spine, what is your approach?
Yeah, the question actually said lipomas. Do you mean lipomas or neurofibromas there, Manjul? Anyway, this is a big problem with, so I haven't seen lipomas, I must admit. I don't think that has been super common in my experience. But I mean, the big problem with these patients is they have multiple tumours, and you know, it can look terrifying. Really, you're really looking to preserve function, and so I try and do as little surgery as possible, unless you know, there is a deterioration of neurological function due to compression. And in that case, then obviously you need to operate, but I would try and do as little as possible, unless there is impending or actual loss of function.
Okay, great. So
I think you should be able to see my screen now.
Yes.
Okay, so I might start. Okay, so thank you again for your introduction. And I also have to say thank you to Nora and to Kate for giving such an overview on tumors and also on neurofibromatosis. And this is going to be a final talk, which is basically related to focusing on the management of peripheral nerve tumors in neurofibromatosis. So Kate already mentioned that we are talking about genetic disorders, which are autosomic dominant inherited disease, and typically present an age-depending penetrance. Neurofibromatosis encompasses several forms. It has initially been classified at the beginning of the 90s by Riccardi, but then more recently there were some other forms which are also included. However, what we know that statistically, they are not all impacting in the same way, and the most frequent statistically types of neurofibromatosis are NF1, which is also known as von Recklinghausen disease, neurofibromatosis 2, and schwannomatosis. Now, all of them are quite interesting for the peripheral nerve surgeons because there is a significant involvement of the peripheral nervous system. And this is especially so when we focus just on NF1 and schwannomatosis. Now, something which is also interesting to consider is the histotype of peripheral nerve tumor, which is involved. So neurofibromatosis 1, as Kate already emphasized, basically includes neurofibromas, where schwannomas are more present in NF2 and schwannomatosis. Now, we are going to mostly focus on neurofibromatosis 1 in this talk, which, as you know, is a genetic disorder that impacts the whole body, and it's also related to peculiarities that may change the physical appearance of the patients. And this is probably why patients with neurofibromatosis have impressed the collective imagination a lot, and we may consider that probably the representation of witches from the Middle Age was inspired by a patient with neurofibromatosis, as well as the famous character of Quasimodo the Hunchback in the book published by Victor Hugo, Notre Dame de Paris. But we also have some historical characters. We have Joseph Merrick, the so-called Elephant Man, who inspired the famous movie by David Lynch and then a remake with Anthony Hopkins starring. Although recently it was clarified that probably this was not exactly a case of neurofibromatosis. And what we have to say that not all patients with neurofibromatosis present such disfigured appearance, because we have a very wide spectrum of phenotypes. So apparently one of the most beautiful men in the world seemed to have a brother affected by neurofibromatosis, and he might be also affected by a very mild form of neurofibromatosis. So we have a wide spectrum of phenotypes. We have something like more than 5 genetic mutations which have been detected, but currently we do not really see a direct correlation between the type of mutation and the phenotype, except with the exception of the so-called microdeletion. This is found in a percentage between 5 and 20% of patients, and there is a very typical phenotype with facial dysmorphism, big hands and feet, hypotonic shoulders, and these patients present a very high number of neurofibromas. And unfortunately, as Kate already mentioned, there might be also issues related to low IQ and a lot of mental health issues. Now, neurofibromatosis, as I mentioned at the beginning, is particularly interesting for peripheral nerve surgeons because there is a large percentage of patients, up to 30% of patients with neurofibromatosis 1 that can harbor peripheral nerve tumors. And regardless of the statistical impact, the fact is that peripheral nerve tumors in patients with neurofibromatosis have peculiarities which distinguish them from peripheral nerve tumors in the general population. So one has already been mentioned before, and it's the fact that in the general population, sporadic forms mostly are related to schwannomas, and it seems that schwannoma-neurofibroma ratio is 9:1, and it is reversed in the patients with NF1. But it's not the only peculiarity. Patients with neurofibromatosis present the whole spectrum of peripheral nerve tumors, and the ones that we mostly focus on are peculiar forms that are found only in neurofibromatosis, which are the plexiform tumors, and then, as we already saw before, the malignant forms. So talking about plexiform tumors, we have decided that we can actually distinguish plexiform schwannomas and plexiform neurofibromas. Now, plexiform schwannoma is actually quite rare. It's less than 5% of overall schwannomas. It is not associated with NF1, but it's found only in neurofibromatosis 2 and schwannomatosis. And the association of a plexiform schwannoma and a meningioma is considered enough to diagnose a NF2. Plexiform schwannomas are usually found in superficial soft tissues and in the head or neck area, although occasionally, like for instance in this case, which was reported by Japanese authors, may also affect the brachial plexus or other nerves. What is important to keep in mind is that a plexiform schwannoma is not predisposed to malignant transformation. Now, plexiform neurofibromas are the ones that we usually deal with because they are a very typical variant in patients with neurofibromatosis 1. We can find them in up to 40–45% of patients. They typically grow along the brachial or the lumbosacral plexus or affect nerves of big caliber like the sciatic nerve. And their macroscopic appearance is very typical, and this is why some American authors have named them bag of worms. And this is related to the fact that there are multiple fascicles which are interbreeded. Radiologically, plexiform neurofibromas present a very typical features. We have the so-called target signs, which is typical of these lesions. And something that we have to consider is that we know that these tumors present a constant, continuous growth. There is actually a correlation between the growth in terms of volume and the age of the patients. And we know that the growth of these tumors is something that mostly happens during the adolescence. But these patients also present the risk to develop new tumors, and this has been quantified as 0.6% per year. Now, as I said, these tumors grow and they may affect all the parts of the body, disfiguring the patient. These are not cases I personally dealt with. These are two patients which have become famous, unfortunately, in history. The patient with the facial neurofibroma had eventually a tumor weighing 6 kgs, and the tumor on the leg was up to 30 kgs. The following are cases I dealt with, and as you can see, we might have the whole body affected. We may have an intracranial and extracranial growth of the tumor. We may have also tumors affecting the cranial nerves, like as you can see here. This is an example of a girl that developed first a significant compression on the spinal cord because of an intracranial neurofibroma, and then she also had the growth of the plexiform tumor on the brachial plexus. We have also examples on the limbs. very frequent, especially the elephantiasis disfiguration on the legs. But we can also have cases involving the genitals, for instance, like in these cases. So the constant growth of these tumors is also one of the problems, and because not all the cases may actually be given indication for surgery, there are attempts of medical treatment, although I have to say that they are still largely experimental. There is no clear evidence of reduced tumor growth, and we also have to consider that they are often burdened by side effects which are not negligible and that eventually cause the discontinuation of the treatment. So the most important thing, as we have already mentioned previously, is that plexiform neurofibromas are predisposed to malignant transformation. And this brings us to bring of what is the main issue in patients with neurofibromatosis, and which is the high incidence of malignant tumors. We know that MPNST are sporadically diagnosed in the general population, whereas unfortunately 50% of these malignant forms are found in patients with neurofibromatosis. And we also notice that there are some differences if we compare the onset of an MPNST, which is a sporadic form, in a patient affected by neurofibromatosis. And one of the things that we see is that there is also a risk of transformation from pre-existing benign forms. This is something that already Kate Drummond highlighted. It's a risk that has been calculated equal to up to 13%, but when we just focus on the subgroup of patients with the microdeletion, this risk may eventually double. So this is a really significant issue that we have. Considering also that the average age of onset is earlier, patients with sporadic forms are usually diagnosed with a malignant form between the 3rd and the 6th decade, but in patients with neurofibromatosis, the average age of onset is 26. And as I mentioned before, the majority of these forms, 2/3 of these cases, are actually consequent to a malignant transformation of pre-existing benign tumors. This is, for instance, one of those cases that we followed. Now, another thing is that when we try to see what is the follow-up for patients with MPNST in neurofibromatosis, it seems that the patients with neurofibromatosis may present a worse prognosis. And this has been attributed not to the fact that there is a different biology of the malignant tumor, but probably mostly to a delay in diagnosis and treatment. So why does that happen? Because if a sporadic form is malignant, usually we have a very alarming clinical presentation. There is a fast-growing mass along the course of the nerve. They might be also associated with changes in the skin overlying the tumor. And then, as it was also mentioned before, these patients start to experience excruciating pain, and they also develop a rapidly progressive neurological deficit affecting the distribution of the tumor, of the nerve of origin of the tumor. This obviously causes a red flag, raises a red flag, and patients may go and seek for medical advice earlier than patients with neurofibromatosis, because in patients with neurofibromatosis, very often the malignant transformation happens with a silent clinical, with no clinical manifestations. And also, this is important to be considered because some of these cases, 1/3 of these cases, can actually present malignant transformation in deep locations, like the pelvis or the mediastinum. But also in big masses which are exposed, malignant transformation may silently occur in lesions that have been there for a long time and have been always treated and considered benign. So this is related to the fact that we have a subgroup of neurofibromas, which are the so-called ANN-UBP, which do not present any morphological or radiological difference when we compare them with the pure benign neoplasm, but then they present signs of malignancy, which can only be detected on histochemical and molecular analysis. And we know that these tumors are the ones that are mostly predisposed to undergo malignant transformation in these patients. So, for instance, if we have a look again at this picture of this patient that I showed you just a few slides before, when I operated these patients removing those three big masses, the histopathology defined the one on the brachial plexus and the one on the forearm as already malignant, consequent to a malignant transformation of these lesions. So the big thing is that we really have to think about prevention, and this is something that it's very clear, and that was also very emphasized by Kate in her previous talk. So nowadays, we consider that all patients affected by neurofibromatosis should have a total body MRI. This is the first choice investigation that can help us to identify the presence of the tumors. And then once we have the full balance, the full estimation of the presence of the tumors, we can, once we have, especially we have detected the hidden masses, we can focus the radiological study, the imaging on the tumor, and then follow them up and see what happens. But there is something that we have to consider. Imaging has certainly evolved a lot. We have new imaging modalities. This has also been presented by Nora in its first talk, but yet we have to consider that sometimes the identification of malignant tumors in patients with neurofibromatosis is still challenging. And this is because very often the pre-existing benign forms that will undergo malignant transformation do not show, as I mentioned before, clear signs of malignancy. So something which has already been mentioned before is the fact that size might be considered an indicator for a possible malignancy. And in the literature, you find some evidence that if you have a tumor whose diameter is larger than 6 centimeters, they may be frequently malignant. So when you have a patient with a very bulky tumor, although it might be not associated with a deficit, it might not be associated with pain, it could be worthy to consider that nevertheless that tumor may be predisposed to malignant transformation. And if you have any doubts, definitely a PET is something that can help you to better diagnose whether there is a malignancy or not. And then we have to decide how we treat the patient. We have already talked about the role of biopsy. Nora very well highlighted that biopsy can be dangerous. She specifically mentioned that 1/3 of patients actually can present neurological deficit as a complication of the biopsy. But the problem is not only that. The problem is that if in a patient with neurofibromatosis, where the transformation has occurred in a pre-existing benign tumor, you go for a biopsy, this could actually be misleading. Because the transformation happens in specific areas, and you might not eventually get to the area where the malignant transformation has started. So we would consider that the correct indication is to go for a surgical excision of the tumor. there is something that we have to consider. Patients with neurofibromatosis, as we know, present several tumors. So we cannot give indication for surgery for all the tumors that these patients present. But we usually consider, of course, that symptomatic tumors have to be surgically removed. Whenever we have screened the patient and we have found a radiological suspicion of malignancy, this is another reason to go for surgery. Sometimes, like in the case of the girl that I showed you before, if you have a superficial bulky mass, even if that's clinically silent, it might be appropriate to consider an indication for surgery. And there have been cases where the removal has been considered because we thought that in the future there might be a growth and more significant morbidity given the location of the tumor. Now, talking about surgery in patients with neurofibromatosis. First of all, I would say that there are a few key points related to the procedure that have to be considered. This is not a surgery that can be done with a minimally invasive approach. We need to have a good exposure of the tumor. We need to have a good exposure of the proximal and distal segment of the nerve that gave origin to the tumor. It's essential to work under magnification. Usually I use loops in the exploration, and then once I have to start accessing the removal of the tumor, I will go under the microscope. And as it has already also been mentioned, intraoperative neurophysiology, or at least direct nerve stimulation, is something that always has to be part of the setting for the surgery. When it comes to surgical removal, the main key points about how successful can be your surgery are related to the site of the tumor, the type of the tumor, which is related to the possibility of performing a radical excision, and also what are we going to do in case of post-surgical management. So the location of the tumor, obviously there's no doubt that if there is a growth of a tumor on the lips, the approach, the exposure is quite easy. But when the location of the tumor is deep in the pelvis, or for instance in the rib cage, then it might be more complicated, and it might be needed to work in collaboration with other surgeons. So, for instance, this is an example of a tumor that was embedded in the psoas muscle. And I collaborated with a general surgeon. We prepared the patient, for instance, with an incannulation of the ureter, and then we identified the tumor that was next to the psoas muscle, and then we proceeded to the unblock removal. This is another situation that was a bit peculiar. This was a patient with neurofibromatosis where we considered that we might have a posterior approach, given that the tumor was very close to the coccyx. So what we did is that, as you can see here, we exposed the coccyx, we removed it, and then we created like a window that allowed us to scoop out the tumor. And this was also a tumor that seemed to be benign, and that on histopathology turned out to be under malignant transformation. The possibility of a radical excision is something that also has to consider the histotype of the tumor. In schwannomas, we can always get a radical excision. Usually we prefer to do that with an unblock excision, but sometimes in cases of very bulky lesions, we have done a piecemeal removal. And for neurofibromas, there are cases where we can also go for a radical excision. But there are cases where this is not possible because we would eventually cause a functional deficit. So this is, for instance, a case of a patient with a bulky nodule on the median nerve at the axilla. But you can see that after you have removed the tumor that was like a big mass, still you have small tumors which are present in the structure of the nerve, and this of course wouldn't be able to remove because we would cause a damage to the patient. So we only focus on removing the big mass. Sometimes you have to accept that you have to go for a partial excision, like for instance this case when there was a removal of the tumor from the lower trunk and also big tumors from the vagal nerve, but they were nodular, so they could easily be removed. And sometimes, and this happens quite frequently with plexiform neurofibromas, you have to accept that there is no possibility to excise the tumor. In this case, we went for surgery anyway because the continuous growth of the neurofibroma on the common peroneal nerve had caused a foot drop, and the decompression of the peroneal nerve, although with the neurofibromatosis transformation, actually allowed the resolution of the pain and some functional restoration. In plexiform neurofibromas, you also have to consider that you have other difficulties. One of the things to keep in mind is that plexiform neurofibromas very often are covered by a very thin skin, and therefore after the surgery you may have complications related to the mal skin healing, and also the fact that these tumors may have a very large extension. And during the surgery, there is a constant bleeding, which is not particularly significant, but which at the end of the day may result in a consistent loss of blood. So if you have a case of a patient with neurofibroma, like for instance, like here, extending all along the sciatic nerve from its origin till its terminal branches, the option is usually to consider to do the removal in several stages and plan more than one procedure. For the malignant forms, the mainstay of the treatment is always the radical excision of the tumor. But the big question is, and this is something that we already talked about during the discussion after Nora's talk, is the resection of the nerve always necessary, always mandatory? Well, as I said, I think we have to consider the different biology of MPNST in comparison with the other sarcomas, although they are still grouped together. And nowadays, we know that when you have a tumor which is not infiltrating, still well capsulated, we could actually try to remove it, saving the nerves of origin. So this, for instance, was a case of a pre-existing benign form that started to develop a malignancy. The patient developed pain, severe pain, and there was a very rapid, massive growth of this tumor. At surgery, the tumor was perfectly capsulated. The femoral nerve could be spared. And this is actually one of the cases I mentioned before, when the oncologist insisted that the patient would go for a revision surgery that unfortunately resulted in a useless procedure because the tissues that were surrounding the tumor were actually negative on histopathology. The resection of the nerve of origin and the surrounding tissue is something that should be recommended only if there is an evidence of infiltrating malignancy. And this is something that most of the times you already suspect before the surgery because the patient presents a functional deficit. And something that we have to consider is also that once you have removed the tumor and its nerve of origin, you have to try to restore the function. Now, graft nerve reconstruction is not an option. First of all, because usually the segment of the nerve that removed is going to be particularly long, because you try to get the segment of the nerve which is not infiltrated any longer. And also because you will refer this patient for radiotherapy. So the best option is that you try to restore the function with the nerve transfer, which is distal to where the tumor was removed, or with muscle transfers. Then there is something that I would really like to focus on, and it's the fact that still nowadays there are some physicians that give an indication for amputation in these malignant forms. we actually have no evidence in the literature that patients who have been submitted to amputation presented a longer survival on follow-up, but the quality of life for these patients has been devastated. So there is quite a significant group of physicians that now consider that amputation should be absolutely contraindicated. Finally, let's not forget that if surgery with radical excision of the tumor represents the mainstay, nevertheless, we have to consider radiotherapy for prevention of all local recurrences, and andron therapy seems to be more effective than conventional radiotherapy in this aspect. Chemotherapy is also an option, although it has not proved to be so useful in follow-up studies. So my conclusions are, we have to really be aware of the fact that NF patients present a significant risk of developing a malignancy. We have to pay attention, especially to patients in their adolescence and their early 20s, because this is when we mostly see the malignant transformation occurs. We have to focus especially on patients where genetic assessment detected a microdeletion. All patients should be studied with a total body MRI, and we have to consider that surgical removal of clinical silent bulky lesions may actually be useful. I just would like to mention that we are going to have a WFNS conference in next month, and this might be also the opportunity to talk more about these kind of issues. And I'd like to remind you that we are trying to work as much as possible, increasing our network, and this is also why you can follow us on our social media. Thanks so much.
Thank you very much, Debora, for this impressive talk and overview, covering, well, all the important aspects of what we deal with every day and what we need to also think in the future how to adapt and change our strategies. So we have run just slightly late. So far, there are no questions from the audience. Any final comments or questions? Rachel, please. I'm sorry, Kate, please.
Just a comment about the PET scans, which, I mean, we don't have the availability of a full body MRI. So when we start with our patients, the first thing we do is screen everything, though, and determine what their disease load is and whether they've got any plexiforms. PET, even in patients without a malignancy, often has quite high hotspots, and we've had them biopsied sometime, and they're just a regular plexiform. I think it's only useful if you have the facility to do it serially, which in many places that's not possible, because your first PET scan, if when you suspect a malignancy, you can only really interpret it properly in the light of a previous PET scan, or that's what we've found. We've found it to certainly not be definitive. But I'm interested in, am I missing something, and should I be doing something different for these patients?
I completely agree on that, that you need to have a follow-up and not just one PET and that's it, because then I think you will not know a lot more than before. I completely agree with you. Any other opinions on that?
Well, sorry, maybe I didn't express myself correctly. PET is something that I would include in my diagnostic assessment, not as a regular screening tool, but when I have some reasons to suspect that there is a malignant transformation and imaging has not confirmed that. So then PET may be an additional tool. And then, of course, using PET on follow-up in some cases of suspected lesions is what I also do. So probably I delivered the wrong message during my talk. It's not that I think we have the same message, just slightly different nuance.
Okay. Any other comments, questions? No? Okay. Then, Debora, I will leave it to you to close the session. And thank you very much for organizing.
Well, first of all, thank you again, Christian, for your participation and the fact that you really chaired the webinar, offering very, very interesting remarks and comments. I think this webinar has demonstrated that we still have dark sides when we deal with patients with neurofibromatosis or generally talking with tumors. And we should probably focus more, work more on this chapter of neurosurgery. These are pathologies which are kind of somehow neglected. Nora mentioned that a lot of patients don't get a timely diagnosis. And this is also something that requires probably more knowledge in the physicians. And also there is a clear need for a multidisciplinary interaction when we deal with patients with neurofibromatosis. This is partially done, but I think probably not enough. And we need to be a little bit more persistent and try to develop those aspects more than we have done until now. And as we were saying during our chat, I think we probably have to reach out also to the other specialists, like the oncologists, and try to offer them what is our perspective for these lesions, and try to interact more. Maybe it could be interesting also to have the the opinion of Nora, and then we, since we are late, we probably have to close the afternoon.
So just one perspective from my side. I hope you can hear me well. So I think for me, as being the current chair of the Drummond peripheral nerve section, it is of sense to get connected with the people from oncology, because I think a lot of clinics do have specialized neurofibromatosis approaches. It does make sense to include nerve surgical perspective in that and other way around. So I think this is of importance to see a schwannoma of a peripheral nerve also as a neuro-oncological entity. And I think we are just at the beginning to make everybody feel that this is the point. And I think a lot of the presented talks do point in that direction. And we also now have a lot of data to prove that.
Okay, so once again, thank you to all of you. Have a nice day, evening, dinner, breakfast, wherever you are. And see you next time. Bye-bye.
Thank you.
Thank you all. Good to see you.
Thank you, everyone.
Thank you. Bye-bye.
Thank you.